I'm the Coordinator of Training and Education. Again, I'm just going to go through some housekeeping items before we get started today, and I'll hand it off to Dr. Trexler, who will introduce our first speaker. Another reminder, just to make sure that you all have signed in. The registration sheets are out in the front. Those will remain out there throughout the day. If you do choose to leave early, please sign out and then also mark your time. That just lets us know when you guys did leave in case we need that information for continuing education, should you need it. Also, another reminder, if you haven't registered via that link yet, I can actually project it later today if we need. We just would like to capture all your information, also for evaluations and feedback. Finally, for any of those who are hoping to get continuing medical evaluation credits, CMEs, please let me know. I have some forms up here if you're asking only for partial credit. Okay, and then I think that's it. Any questions for me before we get started? Okay, all right, well, I will hand it off to Dr. Trexler. Thank you.
Thank you, Claire. Good morning. So today I think is going to be a really interesting day. Today we've got some real specialized topics. So yesterday was hopefully kind of a broad brush and getting our arms around the big picture in terms of the brain injury and criminality. Today we drill down and look at some more specific topics within that domain. So our first two talks are by Dr. Flora Hammond, and she's going to drill down on the medical aspects of traumatic brain injury, and then also on neuropharmacology, the treatment of people with brain injury. And then I'll do another talk after lunch if I can keep you conscious in your post-glucose state on psychological and behavioral aspects of brain injury. And there we'll talk about some of the more specific cognitive disorders and also emotional and psychiatric disorders associated with brain injury. And then Lisa Osterman will talk about post-release planning and how this applies to folks with brain injury. And then we'll have a brief session at the end on next steps. And I think this is a critical issue. As we said yesterday, we're making some great headway in dealing with this issue. But I think it's probably also apparent to you that we're just scratching the surface of a large issue. And we need to think about where are we going and what are the priorities and how are we going to do it. And I really hope to get your input in that discussion, in that conversation, because we have now less than a year left in our current grant, and we have to think about where we're going and what are the priorities and what do you think is important. So I would really appreciate your thoughts about that. So anyway, so our next speaker, Dr. Hammond, is the nationally recognized brain injury specialist, and she is a physical medicine and rehabilitation physician. She's the chair of the Indiana University School of Medicine, Department of Physical Medicine and Rehabilitation. We also have the privilege of having her at RHI. She's our medical affairs director there. And brings a great deal of clinical expertise to RHI. But in addition to that, Dr. Hammond is the principal investigator on our Traumatic Brain Injury Model Systems grant. So this is one of 16 in the United States. And these grants are awarded based on excellence in providing rehabilitation services to people with traumatic brain injury. And you saw a little bit of the data yesterday in terms of what kinds of information comes out of these 16 centers. They also have a knowledge translation center associated with the Traumatic Brain Injury Model Systems Center, and if you want, it's packed full of useful information. It's the Traumatic Brain Injury Model Systems Knowledge Transfer Center, if any of you are interested. But anyway, Dr. Hammond has brought that grant to us at Indiana University and at RHI. So it's a huge accomplishment. So she's decidedly a huge leader in the field. So please welcome Dr. Hammond. Thank you.
I have it over there on.
You want this one?
I have one.
Oh, okay. Cool.
All right. So what I'm going to talk to you about today is the medical and psychiatric aspects of TBI, and in particular, the chronicity and how it evolves over time. For years, we've thought of brain injury as an event that happens, and then this is what you've got, and then you live with that. And the care that we've given for people with brain injury has mapped onto that. So a lot of services given to resuscitating people after brain injury, but not a lot of thought and services to pushing for optimizing function and making sure that we catch and identify problems going on and optimize how people are functioning psychologically and medically. So today I'm going to give you a glimpse of kind of how dynamic people's function and their medical issues are over time, and how we might do a better job with managing those issues. As I said, people have thought of this kind of as an event. So the Gaveston Brain Injury Conference, we got together about 4 times on this issue of brain injury as a chronic condition, starting in 2011 and then 4 times after that. Gaveston Brain Injury Conference is about 40 to 45 people getting together, people across the world who get together to solve issues. And like I said, we decided to tackle the issue of brain injury as a chronic condition. So in 2012, so the first year, we just kind of battled the issue among ourselves of, do we agree with this, that brain injury is a chronic condition? What is it? What are the implications? Is this the right thing for the field? And then the second year, we came up with a definition, and the third year, we came up with a strategic plan. So we meet for 2 days to do this. So anyway, this is one of the outcomes of the 2012 conference is a definition. And this has been really important because before this time, if you use the word chronic brain injury, people wouldn't have understood that term. So here's the term we came up with, and I think it really captures the dynamic issue that I'm talking about. So injury to the brain can evolve into a lifelong health condition termed chronic brain injury. Chronic brain injury impairs the brain and other organ systems and may persist or progress over an individual's lifespan. So persist or progress over an individual's lifespan. Chronic brain injury must be identified and proactively managed as a lifelong condition in order to improve health, independent function, and participation in society. So not bad for a 2-day conference. So what's the evidence that we have lifelong issues happening after brain injury? When you're working with people with brain injury, it's actually pretty evident, but a lot of times what we do is we like to look at the research, the literature, to try to know for sure what the literature is telling us, because our impressions can be a little misleading. So in 2009, the Institute of Medicine, there was an interest in learning from the Gulf War, what are the impacts of brain injury, and so the Institute of Medicine reviewed the literature to date on brain injury and looked for what are the long-term, lifelong medical complications. And they found sufficient evidence, so a high level of evidence for causal relationship with long-term unemployment, so that's not surprising, depression and aggression, a decrease in social relationships, all of that's not surprising. That they found that in post-concussive syndrome, which occurs with mild brain injury, that there was a relationship with memory impairment, dizziness, and irritability. That in severe traumatic brain injury, there was indeed cognitive deficits. Again, not surprising, but we like to review the literature to make sure we're not missing things. And in open brain injury, so penetrating brain injury, they found that there's evidence for decline over time, so cognitive decline. And with professional boxing, relationship with dementia pugilistica. With moderate and severe brain injury, they found a relationship with Alzheimer's disease and other dementias, as well as Parkinsonism. And they also found a relationship with deficiencies in pituitary function and growth hormone. And I'll go over some of those findings to kind of show you what the problem is there. And then also with moderate and severe brain injury, as well as penetrating brain injury, that there's a high relationship with seizures. Less strong evidence, but suggestive evidence, that there's an issue with complete as well as attempted suicide and psychosis, that mild TBI with loss of consciousness has a relationship with Alzheimer's. There's more recent work that calls that into question, but the literature back in 2009, that was the conclusion. That mild TBI has an association with ocular and visual motor disturbance, and that the people who are experiencing mild TBI in the Gulf War were having a high association with post-traumatic stress disorder, and of course with moderate TBI that they're neurocognitive impairments. So not too surprising when you're working with people with brain injury. So I'm going to go through some of these issues just to kind of highlight the problem and some of the dynamic nature of it. So seizure is a big one, and seizures may occur over time. Even up to, there's a study done here at the bottom that just shows even after 10 years that the risk of seizures compared to the general population is higher. So this is an ongoing issue that somebody might be at risk for. About 50% who have a seizure are only going to have one seizure. But what that means is about 50% who have a seizure are going to have more than one seizure. So it's something that we need to follow, and there is a mortality risk with seizures as well. So it's an important medical issue that we manage properly. And then medications that we use to control seizures also have a lot of side effects, so we also don't want someone to unnecessarily be on medication. So it's a very important medical issue that we address. Sleep disturbance is incredibly prevalent after brain injury. Just subjectively, 70% of people complain of chronic issues with sleep disturbance. Objectively, that's about 30 to 45% that have some kind of finding when we actually do formal sleep studies. So why is that important? Well, a lot of the problems of cognitive impairment, irritability, depression, all these various symptoms of traumatic brain injury can be made even worse when someone has sleep deprivation. Also, with obstructive sleep apnea and even just poor sleep quality, we're finding in the general medical population that there's a high incidence of medical complications related to sleep disturbance. So you know you've heard in the news different study findings recently with sleep disturbance being associated with increased risk of hypertension, cardiac disease, diabetes, obesity, and mortality. So it's an important issue, and of course, always worried about the impact of sleep quality and fatalities from or injuries from motor vehicle crashes. So there's also a lot of evidence that neuroendocrine problems, so the hormones that our body uses for our brain to communicate with the other organ systems in our body can be off after brain injury. There's an estimate that 30% of the people with moderate to severe brain injury will have this problem. So this problem is particularly an issue for moderate to severe brain injury. It's unusual for mild brain injury. But here 30%, and interestingly, if you do assessments early on and then you repeat those assessments after 1 year, 5% of them had normal testing early on, but then showed up as having a problem later. So there are people that could test positive for neuroendocrine dysfunction later, even though you screen them earlier. So we have to keep that in mind, that that is a dynamic picture as well. So here's some of those pituitary neuroendocrine dysfunctions, some examples of that. Growth hormone is one of those. So growth hormone deficiency is present in 20% with moderate to severe traumatic brain injury. And the reason these are so important is these neuroendocrine abnormalities can cause, the hormones are in our body for a reason, to help us function optimally, functionally, psychiatrically, and medically. And so when we have a deficiency, we can see abnormalities in that. And so here's a list of some of the problems you can see with growth hormone deficiency. Things like obesity, difficulty losing weight, cardiac atherosclerosis disease, decrease in muscle mass, increased cholesterol, irritability, sleep dysfunction, perhaps cognitive dysfunction, and depressed mood. So these things on the bottom are things that we're already dealing with brain injury. Maybe they could be explained in part from growth hormone deficiency, or they could be masked. And so you would think, oh, those are just from brain injury, and if you don't do testing, you wouldn't pick up on the fact that we might have an opportunity to make this better for them and also decrease some of their cardiac risk by catching it. So similarly, thyroid dysfunction, it's less prevalent than growth hormone dysfunction. It's the more common of the ones that your primary care physician or your brain injury physician might be checking for. That's an easier test to do. And about 5% of those with moderate severe brain injury have that issue. And it also causes a range of problems such as weight gain, a lot of times sleep disturbance, perhaps cognitive impairment, muscle weakness, and again, issues with cholesterol and cardiovascular. Gonadal hormone deficiency, so for females, FSH and LH, testosterone as well goes into this category, and there's an incidence, prevalence of 10 to 15% of people with moderate severe brain injury having this problem, and so we're not going to pick up on this unless we test for it, but you can see it actually maps onto a lot of the problems that people have after brain injury. A lot of people after brain injury will have difficulties with sexual interest, and sexual dysfunction. 40 to 60% of people after brain injury complain of sexual dysfunction issues. So this may or may not be one of the problems, but it's worth considering. And also cognitive impairment, again, could be in part due to deficiency in this area. So all those neuroendocrine hormones really need to be checked, particularly in people with moderate severe brain injury and other risk factors for having that. There's also amino acids could be deficient. So a nice study by Dr. I don't know how to pronounce it, but anyway, it's a nice study looking at amino acids. So amino acids are they're the building blocks of for our body to function. So they help build proteins. So antibodies. Protein synthesis for brain repair, so we use antibodies for fighting infection, we use proteins for carrying oxygen and doing our various functions. Most importantly, the amino acids are used for creating neurotransmitters. And you're going to find in the next lecture, neurotransmitters are really important for how our brain functions. And that's how we communicate, is these neurotransmitters that are floating around in our blood. And that's even the whole purpose of using medications, is to change the neurotransmitter balance. So you can imagine if your amino acids are low and your neurotransmitters are off because of that, really using medications or other things may not even be addressed until we can address this. They have this one study on the bottom did supplementation and actually found that it was still low in many people even after supplementation, but it's worth assessing. Psychiatric diseases. This study actually points out the high prevalence of the issues of psychiatric disease. Particularly in this study, they found 20% with psychosis. That's higher than what I've seen in my patients, but it's a number that catches your attention. A big issue with suicidal ideation, suicide attempts, and unfortunately completed suicides. Depression, it says 18 to 61%, so it's a range there. Mania, PTSD, aggression, and you see the range and the numbers there kind of depending on what population is being studied. 50% developing some type of major mental disorder following their brain injury, and 23% developing some sort of personality disorder after the brain injury. Dementia. So this gets a lot of the press. A lot of people, because it's gotten press attention, a lot of people are quite concerned about the risk of dementia. It's been kind of a controversial thing. From one study to the next, we found different things in regards to relationship with dementia. So I mentioned earlier that the IOM report did find evidence support a relationship with Alzheimer's disease and severe TBI, and here's the Gottlieb study, a review that shows 2 times the risk of developing Alzheimer's and other forms of dementia, so it's not all just Alzheimer's, after moderate to severe brain injury. And that's after adjusting for age, that with severe traumatic brain injury, people were at 4 times the risk of compared to the general population for developing some type of Alzheimer's, some type of dementia. However, interestingly, Dr. Domz O'Connor recently came out with a study showing the opposite. So she looked that there wasn't this relationship. So she looked at people with traumatic brain injury with loss of consciousness, and she did not see elevated risk for dementia. What she did find, though, is really interesting. She found that there's an increased risk of subsequent traumatic brain injury. So people who had a brain injury with loss of consciousness had other brain injuries with loss of consciousness, and that was associated with a higher mortality rate. So risk of re-injury being a really big issue, and at least in her study, a bigger issue than the dementia. So health services utilization, this can be a marker of the burden of medical issues going on. Health services utilization is much higher for people with brain injury. This is a study by Dr. Cameron that took a group of people who were hospitalized with brain injury and a group of people who were non-injured, and then followed them for 10 years and found that people with brain injury have 1.5 times the number of hospitalizations, were hospitalized 5 times longer, and had more physician claims, so more health care claims for seeing the physician. So many of the findings I'm going to show you now come from the Traumatic Brain Injury Model System, which Dr. Trexler was just telling you about. We in Indiana happen to be one of the 16 sites. This gets competed every 5 years, so this is a map. The yellow shows the sites that are currently funded. Because it's every 5 years, the sites change. Some of the sites have changed over time. The red ones are the ones that are still being paid to follow up cases, so they're still active but not enrolling. And the gray ones used to be a site and they're no longer following people. So this is the core of the TBI model system, is that we have a longitudinal database that we have been following people with moderate to severe brain injury, people who go to an acute care facility within our reach, then come directly over to inpatient rehabilitation. So in our case, they go to either Methodist Hospital or St. Vincent's Hospital, and then they come to the Rehabilitation Hospital of Indiana, and then we discuss this database with them and enroll them if they agree to that. So it's people with moderate to severe brain injury who receive rehabilitation. This has been in place for now 25 years, and we've enrolled over 15,000 people into this database. So this is kind of like the Framingham study for brain injury, where we're really, now over the past 25 years, we're really at a point that we have learned a lot from the people that are participating in this database. We've learned a lot about the medical and psychiatric complications, the healthcare services. We've learned a lot about outcomes and outcome prediction. We collect a lot of information about them and about their injury, and then we contact them at year 1 post-injury, year 2, year 5, year 10, 15, 20, 25. As long as we're a funded site, we'll call them and find out how they're doing, and that helps us learn about brain injuries. So now I'm going to share with you a bunch of studies and what we found out of the Framingham for brain injury. So first, just looking at the issue of rehospitalization. So how often are they hospitalized after we discharge them from rehabilitation? And what we found is in the first year after injury, that's the highest time period when people are going to be rehospitalized. And that makes sense. They've had an injury and they've got a lot of risk for getting rehospitalized. And what we found is 28% required rehospitalization in that first year. In the subsequent years, this study looked at 10 years out. In the subsequent years, it's a little less prevalent, around 22 to 23% of people were requiring rehospitalization. This graph here, just on the bottom, shows the year post-injury and if they were hospitalized, and shows the percent of people hospitalized. So from year to year, that rate varies, but the numbers down here are kind of the average over the 10 years. And you'll see, so the solid red line is the that first year post-injury, and across the board was always the highest reason, or highest time post-injury. So then the next question is, why are people needing to be rehospitalized? And we have pretty broad categories in our database, but what we found is this red here. So you've got year 1, 2, 5, 10, and then the color is the reason for rehospitalization. The red is orthopedic or reconstruction. So that includes any kind of orthopedic procedures, maybe hardware removal, needing reoperation because of a fracture or something, or an infection. Well, infection would be elsewhere. Reconstruction, which could be from facial injuries, also includes cranioplasty, which is quite common, especially in the first year. That's where someone had part of the skull removed to decrease pressure, and then sometime after their rehab stay are going to be readmitted and have that plate put back on. And so that happens a lot in the first year. So you can see this red bar is most common in the first year, but it's still pretty common for them to have orthopedic and other reconstructive procedures even out to 10 years. Now, in here would also be new injuries. So if someone fell and had a fracture, they might be hospitalized. So this could include new injuries. You'll see the yellow is infection. And so infection is a pretty big issue throughout all the years. Seizure, neurologic. You'll see rehabilitation is in blue, and there are a number of people who get readmitted for rehabilitation during that first year, and it's much less common over time for people to get another dose of rehabilitation on the inpatient side. So what about mortality? What happens to people's life expectancy after a brain injury? So in this population of people with moderate to severe brain injury, we found that people are 2 times more likely than the general population to die, with a reduction in the life expectancy of 7 years. What we found is the most frequent reasons that's listed on the left-hand side of this slide are similar to the general population. We've got cardiovascular, number 1, in our cohort, similar to the general population. We found that unintentional injuries are quite common. Septicemia, cancer, pneumonia, those things are very common in our list of reasons why people are dying. But what's really interesting is when we then go try to compare that to the data that we have for the general population, what we found is some of the things that might look like they're less frequent are a really big problem for people with brain injuries. So people with seizures, so the seizures are less frequent of a problem or cause of death, but the people with seizures are 37 times more likely to die than in the general population. So when someone does have an uncontrolled seizure disorder, this is a pretty important issue. We also found septicemia. People were 12 times more likely to have septicemia and die than in the general population. Pneumonia, aspiration pneumonia, other respiratory diseases. Digestive, which digestive includes liver disease, and this includes a lot of people who have substance abuse issues prior to injury and have done damage to their liver and have some pre-existing things that are causing a problem. We also found external causes of injury, so unintentional injuries, assaults, falls, homicide, and also suicide. So the unintentional injuries, one thing to note with the assaults, 4 of the 6 people in that study who had died of assaults actually that was the cause of their original injury, was assault. So one of the risk factors is if their original injury was from an assault, to really assess the risk of repeat injury. Now that might be because of their high risk behavior ahead of time that got them into being injured to begin with, or it might be their environment, but worth considering trying to think through if there's ways to prevent a repeat assault. A lot of the things that get someone into an injury put someone at risk of having an injury. So alcohol use, high-risk behaviors, but then also the injury itself now can put them at greater risk of another injury. So with brain injury, you can have a decrease in judgment, an increase in being very impulsive and kind of acting on your thoughts, being judgmental and then acting on that. You can have a decreased awareness of your own deficits, which then may impact others. Difficulty in appraising the situation and the safety of a situation. Decreased balance, which can put you at risk of falls. Decrease in motor function, also putting you at risk of falls. So a lot of things that can put someone at risk of injury, including difficulties with vision. Medications themselves can put people at risk of falls, can put people at risk of toxicity. And the next slide, we'll talk about toxicity and deaths due to that. In other research studies, they found an incidence of drowning and also choking and suffocation. So things to keep in mind. So this is, we decided in the TBI Model Systems database to look at people who died of accidental poisoning, because that was pretty concerning to me that people would have accidental poisoning. So I was curious about this and what we found. And so this red column here shows the number of deaths due to these various reasons. And when I looked through this, what I found is a lot of these have to do with various stimulants and pain medications. So we've got 13 from opioids, 11 from analgesics, 6 from methadone, 2 from unspecified analgesics. So a lot of these are from pain medications. We've also got 14 that are other, so those also could be pain medications. Then we also have psychostimulants that to some extent, we use psychostimulants a lot for brain injury, although I don't know if these are prescribed or not prescribed. And then, of course, alcohol. And alcohol is a pretty big issue after brain injury, as is drug use. Alcohol and drugs, what we find in the TBI model system and other literature is initially people's use is down, and that makes sense. They've been hospitalized, they've been sick, they're being supervised oftentimes. So alcohol and drug use is down initially, but then over time it increases. But this is kind of interesting. So what we found in the TBI model system is over here, so prior to injury, there was a 22-ish% use of illicit drugs. And then we found a slight increase over time. So year 1, 2, 3, 4, 5, slight increase over time, but not too much. So you would think that just looking at the data cross-sectionally there, think that we've got about 18% that are using drugs, and it's nowhere close to what it was prior to injury. But what we found is that we then turned the data and said, well, of people who are saying that they're using drugs, are these the exact same people in year 2 that said they use drugs, that said they use in year 1, and the exact same people in year 3? And what we found is no, actually the people who said yes were probably lost to follow-up, or maybe they changed their mind and said no the next time. But the people saying yes were new people for the most part. So 45 to 76% of the people saying yes to drug use in the prior year had said no, they weren't using. So you can imagine on the phone, people may not be perfectly honest, and or people are starting to use over time. So our data underestimates the problem of illicit drug use, and same with alcohol. So there's been a lot of discussion about people declining over time. I showed you that there's some the IOM report made a conclusion that people with severe brain injury do have a decline over time, particularly open brain injury. So we wanted to look at, is that true? Are people declining over time? What does our data in the TBI model system say? And then I always, we talk a lot about decline and we never talk about improvement. And so I also like to focus on, well, who's improving? Because we ought to learn more about improvement and how we can capture improvement. So what this slide shows you is we use the Glasgow Outcome Extended Scale, so it's an 8-point scale. And we decided to look if people from year to year were changing on that scale. Were they improving? So if they improved on the scale, that would be in green. And if they declined on the scale, that would be in red. So we've got a lot of green happening here. If they're blue, it means they didn't change at all. So this is comparing year 1 to year 2. And what we found is a good 31% of the people improved. The darker color means a greater amount on the scale. So 12% improved from year 1 to year 2 by 2 points on that 8-point scale. Similarly, there were people declining, about 20-ish% declining. So this is year 2 to year 5. Again, more people improving. Year 5 to year 10, people improving. Year 10 to 15, people improving. Similarly, people declining. More people declining as we're going longer out post-injury. More people improving for the most part early on. But look at these, from year 10 to 15, we've still got people improving. After year 10, they're improving. And unfortunately, I don't think people expect that. And expectations can drive outcome. So this is without people expecting people to improve. I suspect that if we actually targeted for improvement, we might have better numbers. So, so this is a study. So now I'm going to a series of findings. We looked at people who, in the TBI model system, that we weighted to make sure that it was kind of like the. So TBI model systems is very specialized centers, right? We have to show that we have excellence in care and all this stuff, and so it may not represent the general population. So we've found that we're lower on age than the general population. So we've weighted this data set for the next several slides to make it similar in age and ethnicity, marital status, etc., to the national rehabilitation sample. So what we did is we looked at how people were doing at 5 years, and we have 84% where we know that what their outcome was, and the other remaining we don't know what their outcome was. So they could have been lost to follow-up, or they said they were no longer interested in being a part of the model system. What we found is that 2 in 10 die, and 3 in 10 are declining from year 1 or 2 to year 5. So so we've got about half of the people are either dying or deteriorating. So this slide, so when you look at these next several slides, age category is always going to be on the bottom. And this shows that 22% died by year 5. So we had them available at year 1 or 2, and then they had died by year 5. This slide shows that 58% had moderate to severe disability, so a high level of disability, ability to function, regardless of age. So this isn't just an age issue. And that 39% declined from the year 1, year 2 follow-up. So 39% are showing a decline over that short time period. And again, not age-related, so it's not age that is the only risk factor here. And 12% were institutionalized by year 5, and this is in large part age-related. So then we've recently done, with the TBI model system, done a study looking at, well, what are the medical complications that are present at 10 years, and also asking people, do they think they've improved or declined? because maybe our scales are off, maybe we're picking up on something. And then we also compared that to what we're picking up on our scales. And our scales are subjective because we ask the people how they're functioning. So we have subjectively how do they think they're doing, and subjectively tell us the answers to how, do you require help with feeding? Do you require help with toileting? Do you require help with remembering things using the functional independence measure? And then we also looked at a relationship between medical complications and function. So the first thing we did is we asked people, do you think you're staying better or worse? And what we found, so the first group of columns show that people who said they were getting worse. And the red is physically, motorically, they said they were worse. Green is cognitive, and blue is from an emotional standpoint. So cognitive issues, so pretty much all three of those were a big issue, with about 10% saying that they were getting worse in total. And then we have the people saying that they were the same. So most of the people said they were staying the same from year 5 to year 10. So that's good. But then from year 5 to year 10, we've got a lot of people saying that they subjectively think they are better in all of these regards. So again, we as clinicians, in the public, people with brain injury, people who are friends with people with brain injury, we ought to be expecting improvement. Because I don't know that we're going to get it unless we expect it. So then what we did is we looked at the functional independence measure, like that objective measure, versus what they told us. And what we found is that people overestimated their abilities, or overestimated their decline, rather. So with our true measure, we found that about 9%, 5 to 9% were declining, and according to them, more like 9 to 18% were declining in various areas, with cognitive being the biggest area where they were declining. So what are the medical complications they have? What we found were the issues they had at any point in time, including post-injury, were fairly similar to the medical complications that occurred post-injury during that 10 years. And so we've had a lot of issues with people having hypertension, depression, anxiety, high cholesterol, back pain, sleep disorders, panic disorders, osteoarthritis. Those are issues actually that were present also prior to injury for many people. Diabetes was a new onset issue that we were picking up on that may be age-related or other reasons. But what we found is a lot of these high prevalence issues are psychiatric. So 17% with an issue with depression, 16% with anxiety, 9% with panic attacks. So the psychiatric aspects of brain injury are showing up here, that we're seeing at year 10. And in our data, we know when these issues came up. So then what we did is we looked at the relationship of the medical issues to their function. So we have the functional independence measure, what I'm going to show you here. We have the functional independence measure motor scale, the cognitive scale, and what's called the satisfaction with life scale. So life satisfaction. And we look to see if, say, hypertension and some of these other medical complications and some of the psychiatric complications were related to function on those scales. So I'm going to show you 3 of these curves. What it does is it looks at function over time and then relates it to that measure. So in controlling for things like age and ethnicity and gender. And what we found, so for example, if they ever had hypertension, either pre-injury or post-injury, was that related to their function? And it was initially, so for year 1 and year 2, hypertension was related to their function, but it wasn't later. So the red mark is that they had the issue, the blue is that they didn't. And then what we find is for myocardial infarction was one that we found, whoa, there's a big issue with motor function and having ever had an issue with a myocardial infarction, a cardiac heart attack. it was very significant at year 10. So that makes sense that someone with a cardiac problem might start having a decline in their motor function. And then this is interesting for so we looked at depression, and depression had an impact on motor, or is an association with motor function. So, so over time, and you can see this curve getting bigger and bigger. So people who had depression had an issue. Sorry, the formatting is off on the yes, no's. Then cognitive, so their cognitive function had a relationship with the presence of depression at years 1, 2, 5, and 10, with that gap getting bigger and bigger. And satisfaction with life had a relationship with depression, and that didn't really change over time, but it was a big gap throughout the years. So depression, this really highlights what an issue depression is, that it's impacting function, or that we think it's impacting. This isn't a direct causal relationship, but there's something going on there with the relationship. So all in all, what we found is that brain injury, I think I've made the case that brain injury is a chronic condition. I didn't show you all the data, but there's lots of data to support that brain injury is a chronic condition. It's not just an event that happens and then we can leave you alone. We need to actually really monitor, manage. There are going to be a lot of people who are going to recover, and that's fantastic, and they may recover and not need any medical attention. But then there's going to be some people for which the issue is persisting, or actually there's various issues that are getting worse, and those need to be managed. So this is just a cartoon of what that looks like. So some people improving, declining, depending on what kind of issues are happening. You can see with this relationship with psychosocial issues and psychiatric issues that they may have an up and down relationship. So some people are going to bounce, and some people are going to have a decline. Some people will have a fast decline, some people will have a slow decline. So why is this happening? So I just wrote down some reasons why this might be happening. One is, is a brain injury actually triggering a process that over time is then having a deteriorating effect that then triggers things like Parkinson's and Alzheimer's and other types of things, like we hear a lot about CTE in the news. So that's chronic traumatic encephalopathy. So is it triggering a process, laying down chemicals in the brain that actually may be hurting the brain over time? Is it that people with TBI have a loss in function, and then that loss in function is interacting with normal aging, or that the TBI is then causing them to be at greater risk for re-injury? Is it that the frontal lobe damage has now made them even more disinhibited and kind of more likely to get into trouble from difficulty with self-regulation, and then that leads to them being at risk of death or re-injury? Falls, it's a really big issue after a brain injury, particularly with people with decreased balance, or substance abuse causing falls because they lose their balance. Emotional disorders that may be contributing to this decline, as I mentioned. The medical comorbidities and psychiatric comorbidities may be playing a part. A lot of people lack primary care physicians, and so that might be because they get consumed about managing the injury, but not about managing general medical health. A lot of times after injury, people's lifestyles change. Maybe they have to. Maybe they don't have the balance to be able to exercise like they did before, or they don't have the initiation. A lot of times we find that they just don't have the initiation, or they don't have the transportation or the resources. And then, of course, things like substance use, liver disease, things like that could be sources for deterioration. And then on top of that, we have aging. Now, as I showed you, aging doesn't explain all of it, because study after study, controlling for age, we're still seeing a problem. And really, it's probably a combination of those things, and from one person to the next, it's probably going to be different. So I mentioned to you the Gaveston Brain Injury Conference in 2013. After 2012, we came up with a definition. In 2013, we came up with a plan, and our call to action is that brain injury will be identified and proactively managed as a lifelong chronic disease that will result in improvements in longevity, improved level of disability, decrease in expense to society, and improved quality of life. We said we will achieve this through modification of our medical and psychosocial health care delivery systems. So it's a pretty big charge that we need to change our healthcare delivery systems in order to change the trajectory of people with brain injury. That health education curricula actually have to change. So people actually have to be taught, when healthcare providers are learning what they're supposed to do, we need to be teaching about how to do this differently, and that we would be doing research aimed at this issue. And healthcare policy and legislation needs to take into account this, because this is no small feat. So what does it mean to manage brain injury as a chronic condition? So it means surveillance, so we can pick up on the things that we know people are at risk for, so that then we can put into place treatments. It means preventive interventions, so there's a lot of things we can anticipate that are happening that we need to prevent from happening. For example, like falls and seizures and things like that. We need to, a lot of other things that we could be preventing, substance abuse issues. Engagement for self-management. So I'm going to talk a lot about this as we go forward in this talk, because self-management is really how we're going to change this. So we need to get people engaged in helping themselves with their health and their well-being and in charge of their progress. And access to services. So if we don't have access to care, access to the medical professionals, access to the rehabilitation services, that's also going to impact what can be done for people. So this is a cartoon of what medical care looks like now. We provide a lot of services, so the scale here is just kind of make-believe, but this is just all the services that happen at the time of injury. And then as time goes out, so you stabilize, acute care, you hopefully move to rehab or to other level of care, you get home, you get outpatient therapies, you move along, and somewhere along here, it all stops. And actually, year 3 is pretty lucky. I put the X here, but depending on the person, this kind of stops. For some people, they may still have some intermittent follow-ups, but there's not much happening after the first year post-injury to help push someone along. And a lot of the care that we do give is very reactive. It's patient-driven as opposed to a procedure in place that we follow, that we are being proactive. So it's very reactive. Our visits are very short, and they're infrequent, and they're not driven by a protocol. We try to do some education in those visits, but it's brief, and therefore there's pretty low engagement on being on the same path for the treatment. And of interest to this, because a lot of times when we think about self-management, we immediately in brain injury, we think, well, we don't have all the brain injury professionals that we would need to do this chronic disease management well. So we were thinking, well, we'll look to primary care physicians to do that. Well, primary care physicians already have so much on their plate when they're seeing people just for general medical health, let alone the issues that people are at risk of with brain injury and having to keep up with that literature. So it's not very practical. But if we were going to use primary care physicians, or even just for general health issues, are people following up with their primary care doctor? So we did a study and we found no. People with brain injury are less likely to be following up with their primary care doctor. And some of the reasons were the finances behind it, transportation. They can't find a primary care doctor. This study was done back in 2009, so before healthcare reform, so access is a little bit different now. But then more concerning was they didn't feel like they would understand the disability, that they'd have to teach the primary care about their disability, and 3% said they actually had issues with being able to physically access their primary care location. And then screening for things like drug and alcohol use and diet, exercise teaching, smoking cessation, all that were not across the board, at least that people remembered that their primary care doctor discussed those things with them. So this is what we would like. Again, just a cartoon that I made, but yeah, we're going to have a lot of services early on. There's a lot going on when someone gets injured and hospitalized, but instead of dropping off, we'd like to have some stable, somebody watching what's going on and managing it, a protocol in place to help guide what's going on, and there might be epochs where more attention is needed, and then you can get back on base, but that they're not just left to kind of manage on their own. So more individualized, regular interactions with a provider, follow-up initiated by a protocol that's evidence-based, we have preventive outlook in place, that we have surveillance, that we're being systematic. We actually have treatment protocols and checklists such that I remember to do all the right things when you come to see me, and that the care I give is the same the care that someone else might give. Treatment guidelines would get us further along there. There are several treatment guidelines for some of these various issues, like seizures and sleep and things from different other populations, non-brain injury, for example, headache management, those kind of things. So we can borrow from that. And then, of course, there's some unique issues that then your physician needs to take into account with those guidelines being a little bit different with brain injury. We need to be able to stratify what someone's risk is. Case management, behavioral support for self-management, and I'll talk about that, and relevant patient teaching. And then also use of technologies. And then we also need to know, if we're doing all this, are we doing it well? So what kind of indicators would help us know that we're doing well in this? So this is just a cartoon that shows kind of what that would look like if we had some supportive care and use of a case manager. So if we had a case manager, the case manager could manage things in between visits. So that would extend the ability, this lack of resource that we have with brain injury specialists, and also get people moving along and identify issues. So the case management concept. Well, why do we need case management? So there's 8,760 hours in a year, and what the literature shows us is that people with disability spend 3 hours in front of a healthcare provider a year. So that's not going to get someone managing their healthcare issues. So what we need to do is we need to teach them how to manage their issues. So that's going to really mean engaging people with brain injury and educating them. So engaging and educating, and then teaching them how to manage issues and when to call. We presently don't have all those kind of factors figured out, what is the marker for which you should be worried and you should call. When should when should we do what? And what is the infrastructure redesign that's needed? So really to manage this, we need to change how we're doing things. We need to do more group education, more education in general, use of technologies to try to put the patient in charge. And we're making a lot of progress with this. There's a lot of apps being developed, a lot of more educational materials that have been developed. And this whole concept that I mentioned of case management has a part here in being able to support someone in their own management. So when I started thinking about supported case management and how we could do that, I realized actually in Indiana, we have an example of that going on. So resource facilitation, Dr. Trexler and the whole group at RHI have rolled out over the past several years a system of resource facilitation. And now it's statewide, and at first working on things like return to work and school, now decrease in recidivism, and now we're also trying to decrease the impact of medical complications. So this whole concept of resource facilitation, to me, is what we're talking about in regards to supported case management and trying to figure out what each person's needs are and how to risk stratify and figure out what each person needs, right? Because you need to use the resources properly and effectively. And if people want to know more about resource facilitation, or you're wanting to try to figure out how to apply this to someone you know with brain injury, Wendy Waldman is here and is an excellent contact, and she can do a talk. She can talk to you about that one, how to get a consult for that one person. But Wendy Waldman is in the back here. Do you want to stand up for anybody in the room? That's Wendy, and please contact her if you want to know more about resource facilitation. So we can't just do supported care for everybody, because a lot of people, they don't need it. And in fact, they'd be quite annoyed if you're trying to support them and manage them when they don't need it. So important part of this is trying to figure out, well, who needs it and who doesn't. And this describes this well. And the 70 to 80% with a chronic issue, any chronic issue, are probably not going to need any help. They're going to be able to manage their issue on their own. Only a few are going to need supported self-management. And the higher risk, you're going to need more support. And then the really high risk, very complex people with lots of issues going on are going to mostly need case management. So in summary of what we've found from the model systems, the Gaveston Brain Injury Conference, the IOM report, some of the issues that we need to be making sure we're paying attention to from a medical and psychiatric issue are listed here. So we need to be working on function and balance, ocular and visual, motor disturbance, cognitive impairment, mood, depression, irritability, aggression, anxiety, PTSD. All those things seem to be a major issue. Alcohol and drug use, major issue, putting you at risk of mortality, re-injury, headaches, big impact on people's lives, sleep, the hormone insufficiencies, hypopituitarism and growth hormone insufficiency, issues about unemployment, driving, social relationships, social support. Those are very important. They're psychosocial, but then feed into these other issues. And then, of course, we talked about mortality. And if you think about those causes of death, particularly the ones that are greater risk than the general population, we need to have an eye to those things. We need to identify people who might be at high risk for mortality and try to decrease that risk. So people with seizure, sepsis, pneumonia, people who have digestive/liver issues, and then those external causes, substance abuse issues that might be causing unintentional death or accidental poisoning. So why aren't we already doing this? One big issue is it requires a huge redesign, and we need to be taught how to do this, and we probably need some incentives aligned and all that kind of stuff. A big issue we have is a lot of the healthcare reform that's happened has had financial savings. So if you think about asthma and CHF, those have been managed in a way that improves the care, but also keeps people out of the hospital, so it's had a huge financial savings. With a disease like brain injury, where we're underutilizing the care now, it's hard to imagine that by providing the service we're going to decrease healthcare utilization, because we're not giving people access, but perhaps in proactively doing it with the right surveillance, we might have cost savings, but it's kind of unknown the return on investment, other than believing that we will have better outcomes. And then one of the other obstacles is I've talked a lot about self-care, and don't really know with some of the cognitive issues with brain injury and behavioral issues with brain injury, self-care may be kind of difficult for them to be engaged and do their own care. What a lot of times this means is not self-care, but self-care with someone who helps them with their healthcare management. So maybe it's their parent or their spouse or someone who cares about them that can help do supported care with them. There's a lot of unanswered questions in regards to being able to do chronic disease management and what we need to know if it would work. Here are just some of those unanswered questions. So who's at risk of a negative outcome, and who's at risk of a positive outcome, so that we can actually identify and push to get better outcomes. What are the pre-existing conditions that people have that may impact their function that we also need to manage? What are the conditions that develop after injury that we may need to be managing? What of all the different conditions can be self-managed? Like, so diabetes can be self-managed. what are those kind of things with brain injury that could be self-managed? So aggression, depression, substance use, headaches. You know, what of these things can be self-managed? Because not everything can be self-managed. And what are those obstacles for someone being able to self-manage, and how much help and support, and in what way do they need to be supported? And how can we increase the access to the services and get the level of expertise that people need? And lastly, just to summarize, the data I showed you from the TBI Model System showed that 50% are either deteriorating or dying by year 5. So they were alive at year 1 or 2, and then dead or declining by year 5. So that's very concerning. And we really need to be putting something in place to monitoring and trying to change that trajectory. So we ought to be managing it like the chronic condition that it appears it is. There's a lot of gaps in access that we need to restructure how we're doing it. But in the meantime, in Indiana, we already have some of these resources in place, particularly the resource facilitation, as well as just general medical care. I think it's very important for someone to be following up with a brain injury specialist, whether that's physical medicine rehabilitation or neurologist or someone who actually manages people with brain injury. And we have a lot of unanswered questions that over the next decade, I hope that we make progress in this area. So thank you, and please feel free to contact me if you have questions. Questions now? Or actually, I think, are you doing questions? Okay.
Yes, one of the questions I have is the people that you're tracking, what is the age groups, and are you weighting any of the, is it a weighted average, say for example somebody 65 as opposed to somebody 25?
Yeah, so we have the weighted database that some of our studies are used with the weighted database. Now that means just weighted to the general population. All of our studies we control for age. So when we do the analysis, like say we're doing a regression analysis, we'll put age in there so that we can control for the impact of age. Yeah. So, and interestingly, a lot of this is not just age related. Yeah, how many end up incarcerated? We have that in the model systems database, and I'd be guessing right now off the top of my head, but we do have that in the database, and the way that we defined the initial variable, we have a pre-injury variable and a post-injury variable, and they're worded a little bit different. I think one is about felony incarceration and the other early on, and then I think the subsequent is just incarceration. So, but our data, a summary of the data, just as a whole for this cohort of greater than 15,000 people, is on the Traumatic Brain Injury website, which is Traumatic Brain Injury National Data Statistical Center. And so if you wanted to kind of just get the demographics, that would be a great, they would have that on there. Or you can email me and but just if you log onto that page, you don't have to log in, you just go to that web page and they just have a presentation of all the data, the demographics, etc. Anything else I can help with? Great, thank you so much. There's a break.